And first up for our Year 1 awardee updates is Dr. Cornelius Dyke from Stanford Health.
Thank you very much. It's a pleasure to be here. It's been a terrific year. The year's not over, so we're still working hard, but it's great to be here. I'd like to recognize first off my collaborators with this project. I'm a CT surgeon. I am not a computer scientist, but I know some good ones. Dr. Kim is my co-PI. Future Dr. Hashin Rahana working with us. Dr. Rowe is a chief resident in our Department of Surgery, who's going into CT surgery, and he'll starting his fellowship next year. And Dr. Herr is the head of the collaborative computer science laboratory. So I'll go and basically try to stick to the time. This is a much less scientific talk than we just heard. Dr. Vermeer was amazed at your talk. I was very impressed. It also made me very proud that Stanford science is so strong. I knew it was. I've been down to the research facility. It's incredible in Sioux Falls. And I think that the engine of basic science and clinical medicine and clinical science is really super strong and something we should be proud of. So I know I'm proud of it. But it's a great talk. Thank you. My disclosures, I have none, nor do my collaborators. We do have support from the REMS experience. Thank you, Dr. Sledden. The Surgical Research Fellowship where Dr. Rowe worked, and then this grant, of course. And I mentioned my collaborators, some of whom were students and are now doctors at UND, and some graduates, and some of whom will graduate shortly. So thank you to them. I want to talk about a patient that we saw recently. This is an 87-year-old woman with severe aortic stenosis. She had multiple risk factors, including prior sternotomy and CABG. She wasn't a candidate for surgical valve replacements, and her really options were medical treatment and TAVR. And I can tell you that before TAVR came around, in 2012 in this country, she would have been a medical therapy only patient, and her lifespan would have been significantly compromised by that. So she had the standard workup that I'll show you here. We knew she had significant vascular disease. We got vascular surgery consultation before. And this is kind of where we are now. We look at the scans, we look at them with them. We say, gosh, there's some vascular disease there. We need to be careful with that. What do you think we should do? We discussed open access, but we decided we'll just give it a try and see how it goes. So that's what we did. And guess what? We had vascular complications. So we had routine access. We put in a core valve. We put in use the right common iliac for our intraoperative access, and then we had an ischemic leg afterwards that required open repair with our vascular surgeons, luckily whom we had consulted beforehand, so they knew her. And then at the same time on the same table, they expertly repaired her artery, restored blood flow, and she went home on post-op day 5. The problem is this is 4 days after she should have gone home. Usually it's a procedure that takes about an hour. They go home the next day, and so her discharge was significantly compromised for that. So I won't talk about aortic stenosis too much, especially with a cardiologist in the room. I don't want to overstep my bounds, but it's a very common problem, and as we get older, it becomes more problematic. There's a long latency period, and when people get symptoms, bad things happen very quickly. So if Our Lady, who is 87, her lifespan is measured in months or a year plus rather than longer. So the old-fashioned way to do it, cardiac surgery, was really founded on valvular heart disease, and the early pioneers were putting them in an extra anatomic place in the descending thoracic aorta. Alden Harkin, the first orthotopic mechanical heart valve, and then the refinements of the technique with some giants in the field who refined it in the 60s. This name you may remember, Edwards Life Sciences is a very large publicly traded company, and Dr. Edwards was the engineer who worked with Dr. Starr and others to develop these early valves. The father of transcatheter aortic valve replacement is Alain Cribier, who's a French gentleman who trained at Cedars-Sinai, who basically did the first valvuloplasty, did the first in human TAVR in 2002 in a circulation article that was quite famous. And then in 2011, we got FDA approval in this country, and the technique kind of exploded since then. These are the landmarks that I just like to mention, just for the history of development. I think it's interesting. Back when this was going on, this was kind of heretical. The idea of these crunchy, calcific, nodular valves being blown up with a balloon and something foreign placed inside them was very controversial. And the feeling was that you're going to cause a lot of strokes and people are going to not do well. And it's a crazy idea, and surgery should be the only option. Nonetheless, with persistence, and persistence in a very methodological, careful fashion with cadavers, animals, cadavers, end-stage patients, and then finally with well-regulated clinical trials. It was approved first in Europe, and then the United States was behind then. I won't read this to you, but I will, say this is a quote from his paper describing, how the patient looked with resumption of resolution of that high gradient across the heart valve. So it sure did catch up. And if you look at the numbers, blue is transcatheter valves, orange is surgical valves, and they cross in 2017. And this number continues to rise. This is 2018 data, and this is published in 2023. So these numbers keep going up. And right now, transcatheter valves are indicated for patients with severe aortic stenosis at all levels of risk. So that means that low risk means no risk, means anybody is a candidate. And you can see it adopted earlier and earlier and younger patients. At our surgery meetings, I just came from our biggest meeting in Chicago about 3 weeks ago. The big topic was adoption of transcatheter valves in younger patients, even in 65. There's in California, about 45% of patients 65 and under are getting transcatheter valves. And what that means is it's a difficult problem when they wear out in 10 years, 8 to 10 years sometimes, how to manage those patients afterwards. There are ways, but it becomes an issue. And so that, what to do with this rapid adoption in the young patient is a question of controversy. Basically, we used to do them open. Now everybody does them peripheral with percutaneous techniques and percutaneous repair using various closure devices. Patients don't always have the nice arteries that are presented at talks and certainly illustrations, this nice big non-calcific straight artery. We haven't seen that patient yet, but I'm sure they're around there somewhere. So what we decided a while ago, and this forms the foundation of our computer analyzed study, was we decided to look at one of the Achilles heels, which is the vascular complications, which occur in the big trials and occur in the 7 to 8% range. In our series of since 2012 with all encompassing all comers, it was about 5.8 or 6%. So we decided to look at our patients and look and see, what happened if we could predict who had complications. So we looked at clinical characteristics, and then we decided to do a deep dive into the CTA and look at the computer tomographic data. And more than just what's the size of the vessel, is it calcified or not, which is kind of the gestalt of what we do now. So with Dr. Rowe's help, he spent an entire year as a surgical Stanford Research Fellow looking in detail through all of our CTs going back from the beginning of 1,300 some patients, and we looked at things like tortuosity and these things here. What we did is we quantified all these. So we looked at tortuosity, how it measured here, and compared he went through and measured the actual distance with the cursor, and then compared it to the straight line and used that ratio as a measure of tortuosity. We used calcifications and used 8 quadrants and defined where the calcification was. We used a well-known total atherosclerotic burden score and quantified the total atherosclerotic burden. All of this is more than we do in our average patient. I did 2 yesterday. We don't do this, frankly, on every patient. It takes a lot of time to look at these CTs. So it took him, he would estimate probably 30, 45 minutes to score each patient. And I don't know, maybe we should, but when you're doing, 250 or so a year, we tend not to do it. So we found that total atherosclerotic burden, posterior calcification, laterality in our series was a factor, and then the dimension of the right, which is usually where the big sheath is. And Hunter wrote a nice paper about that. So last year, or I guess 18 months ago, we came with TRANSCEND and said, well, how can we do this better? Is there a way of better analyzing these CTs using AI technologies to try to improve the reading of our CT scans? And the next part of the course, I promised future Dr. Rahana that I would not call on her. So if I get any of the computational science confused, it's my fault, not hers or not our team's. But with this group, we dove into the question of, can we automate this process using AI or machine learning to read our scans for us? And the benefit, what we tried to do, our hypothesis was that integrating artificial intelligence into pre-procedural planning will improve our outcomes. And then linking anatomic variants that we see on the CT with the clinical variants that we know are important, perhaps we could develop a scoring system or some metric by which we knew patients were high risk and then could intervene and do something different. We could intervene and do peripheral interventions before a procedure. We could do an open access. We could do alternative access. So there's definitely things we could do to change our clinical path if we have a patient that we know is at high risk. So our aim was using the same data set that Dr. Rowe looked at, the 1,389 patients that were already scored. We already had that data. It was an all-encompassing data set. We already knew which patients in that data set had vascular complications. So that was a benefit. And we thought we'd automatically quantify those key features and then utilize our machine learning to integrate the imaging and develop our risk score that way. So this previously analyzed data set is kind of the foundation. And actually, I think makes it unique because previous work has looked at scores of CT scans, but they haven't been annotated and looked at, I think, as closely as Hunter did when he did his work. So using that as our foundational data set, we took every slice of the CT scan that they had for their pre-procedural, and it was approximately 750,000 slices that had already been measured by us. And then we knew, like I said, which patients had problems, so that was a benefit too. So our thought was, into the initial training, what we would do is basically use our machine algorithm or start writing the learning using, we call it weekly supervised training, where the algorithm was learned to identify the blood vessel, identify where it was, identify segmental anatomy, and then fine-tune it using fine-tuning it using our data set. And then we do some bounding box regression. I call it black box regression because I'm not really sure what this does. But use some of that, come out with some process where we read it, know where the anomalies are, and then add in our clinical features to create some risk scores. So this is a first step, and there's a nice poster that future Dr. Rahana has out there looking at our methodology, just using machine learning to try to improve our background in our knowledge, basically to show that the things that we thought were important in our paper actually were agreed with in the literature. And so using some GPT help, basically a large number, 500 plus papers on TAVR topics, used some fine machine learning activities, and then came up with our own scoring system where we basically kind of confirmed what we thought. So that made us feel good that our manual work was the same. But looked at calcification, common femoral artery diameter, gender was a factor, perhaps because of the size of the vessels. Sheath to artery ratio, that's an interesting factor, but basically has to do with the size of the vessel. And use those, these are what came out in the literature. So these are also going to be things that will help our computer system figure out what's important. If we looked at what's in particular with our data set, peripheral vascular disease, a clinical variable, highly significant, but then these other things, size of the vessel, total atherosclerotic score, and then posterior calcification. This is probably because when you use those closure devices, you can catch the posterior aspect of the vessel. You're not answering your question, are you? I got it. So I think I'm on time. So what we're doing is using two stages. Now we'll focus on the first stage because we haven't got here yet. You may remember last summer there were some issues with access to NIH funding and things, and I have an excuses slide of why we aren't further along, but I skipped it for the matter of time. So we're learning here. We're using these weekly supervised learning where we're letting what we already know, let the algorithm kind of learn what the vessels are, and then we get it back to our supervised learning where we use our clinically derived measurements because we have measurements from each of those scans, and we kind of combine that. It looks like these are important things from the work that future Dr. Rahana did with her literature search. We found this. We're going to include those as possible. And then eventually we're going to take and fuse those things between in step 2 to try to create our risk score. And this is just a nice picture showing our methodology where we're taking the scans, doing this deep learning, initially weekly supervised and then more fine-tuned with our clinical data that we've come up with, and then creating our risk model. We are not at this stage yet where we're predicting risk. We're also supervising because we can go down and rescore. So we rescore our test after we do this machine learning part. We're going to rescore about 100 to make sure that we're not far off. So we're right here. We're going to keep working past the July 1st deadline. We have it. We have all the images stored. Getting images between institutions is not a small task. So that's on my excuses slide too, but that's an issue. But we got it. We have all our scans up there. Our validation eventually, what we want to do is once we create our risk assessment, we're going to try to use it to prospectively validate patients in a clinic because these are a group of patients that are ongoing. And in summary, we think that we can eventually, and I think we're working on it and getting there, leveraging our well-known data set to create an AI prediction tool and potentially change how we do transcatheter aortic valve replacement. Besides TAVR, I'll just mention this could have applicability for future work, grants, et cetera, outside the TAVR space. Anybody looking with peripheral vasculatures, procedures in the IR lab, vascular radiology, lots of different potential targets. So I'll stop there, and I would love to take any questions and appreciate your time. Dr. Gaba.
You're using AI and language models to read all these images and develop an algorithm. So did you have somebody who was an expert and who could guide you how to use AI and
Yes.
this?
So with Dr. Kim in the School of Computer Science and Electrical Engineering is our co-PI, and then future Dr. Hashin Rahana, she's right over there. So I can, who's done the yeoman's work. So they're the experts. I am not the computer scientist, so they're helping with that. Well, our job is, it really is collaborative because we have to work together to interpret the scans, but then how the machine works and the computer science behind it. And this all occurs within Dr. Herr's computational core. So, yes, sir.
This is great work. It's hard to do. It takes a real team. Clinical expertise, statistician, learning people. It's really hard to do. It requires collaboration between the hospital, the medical school. A lot of the data are kind of walled off from you and trying to
Yes, sir.
Places. Make all kinds of deals. It's a real pain in the neck. So congratulations. And it looks like you have a goal to assemble these data and make risk models. And I'm wondering if You're going to maybe try to use it like multivariate modeling or digital twins to predict if I do this procedure in this patient of this age, of this gender, with these risk factors, how successful am I likely to be? How much longer will it prolong their heart health and their life? Are you trying to develop models like that?
Correct. And we're focusing not so much on the extension of life from a cardiovascular point of view, but we are focusing on the procedural variable of whether we can reduce that, 6 to 8% of patients that have a significant complication that can be life-threatening, and by combining that information and the ability to intervene there, I think is significant because there are different ways of doing that. And so if we identify patients that are high risk, other than just, and being more sophisticated about it than, like I said before, just saying, well, this patient's high risk because I can see the calcium there, to do it in a more sophisticated way so that we could perhaps change our methodology. And the other nice thing, I think, is we can test this going forward on patient population in a supervised fashion, of course, but do that. Yes, sir.
Are you proposing that there's a risk cutoff where you would actually use a transapical approach rather than a transfemoral approach for putting this valve?
So transapical, no. And we've done a lot of those. I've done a lot of those, but we started at 58 at the very beginning. It's kind of gone away. No one's really doing transapical anymore, but the way now, the best alternative access now is a transcarotid route. And so we are doing a lot of those. So you actually think about that. You're putting these big sheaths, expose open, the carotid artery open on the right side, and then put your valve in. Instead of retrograde, you're kind of just putting it right there. It's a wonderful technique. It wasn't used initially because people thought, oh, that's going to cause problems with the carotids, but it actually is a great alternative access. The trick is jumping to that because it's a little more complicated. You do have to have access. It's like an open carotid endarterectomy. But there are other alternative access besides the transapical. Yes, sir.
Yeah, good stuff. I'm also working on a similar model for risk identification using AI in respiratory care. And our outputs are environmental, anything from the outside. But that engine that you're working on is identical to what we're looking at.
Interesting.
And so I'll look forward to talking with you guys later on. So as it relates to some of the things that I'm looking at in my projects, in addition to the difficulty and getting the data, let's go move forward. And you can actually model what some of the questions earlier was. Just using AI right now, you can model what can happen afterwards. That'll help your future R01 and your future studies later on. But my question is, what kind of hurdles do you see, going forward? You mentioned a couple already, but then subsequently, you want this as a clinical decision support, where you can actually see the patient right there, make a decision, not an emergent basis, but, you can stratify, you have lots of risk factors there. I only have 4, and so, where do you see yourself in 5 and 10 years? Is this academic? Is this going to be commercial? Because, you have to show, you have to validate, you have to do all the things first. But where do you see yourself in 5, 10 years?
So to answer that part first, I think this tool is going to be a way that every patient everybody gets these preoperative CTAs. So once you get that CTA, you put it into, let's call it the Rahana algorithm, named after Hasheen. And so we put it into that algorithm, and that comes out and gives you a risk factor. And then you can make your clinical decision in collaboration with your cardiology surgery team about how you're going to access. To get to that point, we would have to create our model and validate it. So we'd have to, under an IRB protocol situation, use it prospectively and probably get a score, prospectively see if it matches with, the outcomes that do occur. I think we need bigger numbers. We have 1,000 patients. It seems like a lot, but it's only about a 5% incidence, 5 to 8% incidence. So combining with institutions in this room and these other centers, I think would be a great step forward so we can increase our, event rate and help with our prediction models. So that would probably take a few years. That I think was going to be our plan for future funding, is to try to develop a multi-institutional approach using the algorithm that we developed. There are commercial interest in this, and there's no question there are other things that have done like that. That's above my pay grade, so I'll let the others figure about that. Dr. Chen. Oh, okay.